Okay, good morning, everyone. Welcome to a Monday, a great Monday, and I'm glad to be here. I'm Audrey Russo. I run the Pittsburgh Tech Council. Very thrilled to have this opportunity for 2021 Beyond Big Data. I can't believe that we're doing this remote, but we are. And we have a great crowd and we have an amazing panel, particularly this morning and all through the days. It's just really incredible. I'm very excited to listen. So we're focusing on AI and machine learning, and this is our summit. And we have just, like I said, just an amazing panel, but we're going to kick off the panel entitled Better Healthcare Through Advanced Technologies. Couldn't be more timely and couldn't be more important. And hopefully that we'll have an opportunity for some Q&A, but definitely an opportunity to hear from some amazing people that are working all across the issues around healthcare today. So we are going to be followed with a technical keynote from our presenting sponsor, and that's CGI, entitled Pathways to Building Systems of Intelligence. So after the technical keynote, we're also going to have 3 breakout sessions. They're presenting with presentations from Tom Doyle, founder and CEO from Aspinity, Tyler Norris, senior data scientist from Bountiness, and Catherine Kopp and Brad Price, who are data administrator and assistant professor from West Virginia University. And we consider West Virginia and Morgantown part of the region of Southwestern Pennsylvania. So first I want to take a moment to just really shout out to our sponsors. We can't do this work without them. We rely on them, and hopefully you should rely on them too for the work that you do. For many of you who are not service providers, it takes all of us to make a region. And so I want to thank them and visit them between 11 and 12 in their virtual booth. So we're trying this. We want to make sure that people can do what they might do at a trade show or at a summit like this. And they're going to be available between 11 and 12. So I want to give specific shout out to CGI. They have been big partners with us in all things that relate to information technology and chief information officers, as well as security, and I want to thank them. The keynote sponsor is Risk Focus, Inc., and the panel sponsors are Click and the Consulate General of Canada in New York, and supporting sponsors is Cloudera, DQE Communications, ACNC, Jetstore, Plus Consulting, and Snowflake. And at 11 a.m., you're going to have ACNC and Jetstore. They're hosting a presentation on big data, machine learning, and AI using super fast OpenFlex NVMe over fabrics with Mark Michelon, Director, Partner of Alliance Engineering at the Data Center Systems of Western Digital and DQE Communications. We'll be presenting SD-WAN for your business. And then we'll be hosting at 11 o'clock that hour that I mentioned before, which will be accessible through the Sketch platform, which hopefully most of you have access to. So I am going to be quiet. I'm going to be listening intently. And because first of all, I have 3 dogs in my house right now that are hopefully behaving for 10 minutes, but then I go on mute. So I am pleased to welcome Manoj Mishra. He is the Vice President of Consulting at CGI. Manoj.
Thank you, Audrey. So first of all, again, good morning, all of you. First of all, I would like to welcome everyone to this exciting Beyond Big Data Summit. We, as CGI, is very proud to be associated with Pittsburgh Technology Council. Thank you, Audrey and team, and especially this event. As a technology organization, CGI is making big bets on analytics and AI. I think I said earlier, about 30% of our business comes from analytics and AI. We know it's a big space. And we strongly believe in the power of analytics and AI, not only to transform organizations, but I believe it's going to change the way you and I are living our lives, right? And again, we talk about healthcare. I think it's also going to change specifically healthcare in terms of how medicine is administered, right? No longer we'll get medicine based on statistics, but we'll get medicine based on what Manoj needs, what Audrey needs, and not what has worked for other people. I was talking to Jonathan the other day. By the way, he's great. If you haven't heard his podcast, I would highly recommend you do. I was telling him how when the economists first reported a few years back that data and not oil is the most valuable asset, it took people by surprise. And again, believe me, unlike oil, to get value out of data, you don't have to sell it. You just have to organize it efficiently, apply some machine learning to it, and then you start getting insights out of your own data. There's something that if you look very closely, and we have done this a lot, right? So we do a lot of research on organizations. And if you look at the successful organizations, you will find one thing in common. They know where their data is. They know what data they have. And believe me, not many organizations even know that they have this asset with them. So these successful organizations, they know where they have the data. And more importantly, they build insights from the data, which informs their day-to-day decision. They leverage machine learning. They leverage artificial intelligence to stay ahead of the competition. And that's the mantra. I think the organizations of the future will actually be the organizations who step on this and realize that machine learning, data, and AI is the way to go. I hope you're as excited about this summit as I am. Beyond Big Data provides a very unique forum to hear from industry leaders. And again, I am super excited to be attending this event. I wish you all a very good conference, and I'm looking forward to taking some key nuggets from this conference and hope you do too. Thank you. Back to you, Audrey.
Hang on. So I think we're ready to get started. And I thought that you were going to introduce the panel, but that's okay. I am going to present Dr. Zariel Johnston, Technical Program Manager from UPMC Enterprises. She is also representing the Pittsburgh Health Data Alliance, and she's going to be the moderator. She is going to, we're thrilled to have her and understand the work that's going on at UPMC. And the discussion today is going to be better healthcare through advanced technologies. Please allow me to welcome and applaud and appreciate that she's up this early on a Monday, Dr. Zariel Johnston.
Thanks so much, Audrey, and thanks everyone for attending. We're really excited about today's event, and we're very excited to kick off with this morning's panel. So Better Healthcare Through Advanced Technologies is the title, and we're very interested to hear from this wonderful group that we have assembled on all of their activities in this area. So as Audrey said, I'm Zariel Johnston, and I'm going to serve as the moderator today. I'm a program manager with UPMC Enterprises, which is the innovation and commercialization arm of UPMC. And in my role, I have the pleasure of leading UPMC's activities in the Pittsburgh Health Data Alliance. That is a collaboration between UPMC, Carnegie Mellon, and the University of Pittsburgh that seeks to support research in digital health that has the potential for impact through commercialization. So let's get to today's panelists. We are joined today by an esteemed group. We have Roni Rosenfeld, professor and head of the machine learning department at Carnegie Mellon and leader of the DELPHI research group, also at Carnegie Mellon. We have Jessica Gibson, chief executive officer and co-founder of Ariel Precision Medicine. We have Michael Cohen, chief technology officer of TeleTracking Technologies here in Pittsburgh, PA. And we have Oscar Marroquin, Chief Healthcare Data Analytics Officer for UPMC. So I am going to ask each panelist to just give a couple of words about themselves, their organization, and how they're using data analytics to improve health or healthcare. And then we'll get into the rest of the questions for today. So let's start off with Dr. Rosenfeld.
Hi, good morning. Pleasure to be here. Thanks for inviting me. As Ariel mentioned, I head a machine learning department at Carnegie Mellon University. I have been at Carnegie Mellon for 30-some years, arriving as a student. Our machine learning department has some 30 faculty who do literally all types of machine learning, anything from theory to quite applied. In my own work, I've co-founded with my colleague Ryan Tipshirani a research group that we call DELPHI or DELPHI, choose your pronunciation. Back in 2012, that's 8 years ago, with the goal of making epidemic tracking and forecasting as commonly useful as weather forecasting is today. We made some progress over the ensuing 8 years, and then the pandemic came and made a lot more progress than we ever could have hoped to make by convincing the whole world how important this is and how much we need it. We did most of our work on forecasting flu in collaboration with the CDC, also some other pathogens. And then when COVID came, we've pivoted to COVID, and I'll talk about it more later. Thank you.
Thanks, Roni. Now let's hear from Jessica.
Hi, thank you so much, Zariel, for having me. I'm Jessica Gibson. I'm CEO and co-founder of Ariel Precision Medicine. We are a Pittsburgh-based company that has focused on transforming data into insights for complex health conditions. And last year really accelerated the utility of a lot of the tools that we've created in our platform that's designed to integrate genetic and clinical data into new insights and support physician care for patients based on their individual needs. And I would say the space that we're in when we're looking at complex models of human response to an injury have really helped to accelerate some of the things that we're hoping to be able to support when we're looking at individual patient responses, and how do we help a physician understand the risk for a patient that's right in front of them without having to be an expert in all of the various sources of data that we're integrating, and grateful to be a part of the conversation.
Thanks, Jessica. Up next, we have Michael.
Yeah, hi, this is Mike Coen. Also, thank you very much for including me in the discussion. This is exciting. I'm the Chief Technology Officer at TeleTracking Technologies. I've been in that role, or been in a VP Engineering and CTO role for the past 4.5 years at TeleTracking. For those that don't know TeleTracking, we are a healthcare operations company that's been in Pittsburgh for about 30 years. One of the many things that we do is build machine learning algorithms to optimize the patient's operational flow within various care settings. I'm glad to be here, and I'm honored to be such part of such a esteemed panel, and I look forward to discussions. Thank you very much.
Thanks very much. And last but not least, we have Oscar.
Thanks, Ariel, and thank you to the Pittsburgh Technology Council for asking me to participate. My name is Oscar Marroquin. I'm a cardiologist and epidemiologist, and I am the Chief Healthcare Data and Analytics Officer for UPMC, where I oversee a team of architects, technologists working with our IT infrastructure team under Ed McAllister and Chris Carmody, as well as our clinical analysts and data scientists in a team that, unlike in a lot of other healthcare organizations where there are data and analytics teams set aside to do more on the research side, we are a little bit different in that our team is embedded within operations, and our goal is really to leverage the data that we are generating when we are caring for our patients to derive real world evidence and insights that can help our clinicians better manage our patients. And so in this role, I'm very excited to be a part of this esteemed panel.
All right, well, thanks everyone. And I'd like to take a couple of moments just to set the stage for today's discussion for our audience. And I think it goes without saying that, of course, the coronavirus, COVID-19, is on the top of everyone's mind, and especially when it comes to healthcare and health, and how data analytics could perhaps be used in ways that they have not before to improve and make quick progress to what we hope will be a new normal in the coming future. So as we were discussing some of these panel questions and talking about what we wanted to go through here today, we realized that a lot of the discussion sort of begins with where we are in terms of data availability when it comes to using analytics and applying them to COVID and the pandemic. So I was hoping that first we could start off with our panelists giving their thoughts on where we are along that continuum of going from collecting data, making data available, perhaps combining multiple data sources, all the way through to the endpoint of analytics, which is gaining insights from data. So I'm hoping that we can hear some thoughts from the panel on that. And I'd like to start with Roni. So the question is, where are we today on the continuum from understanding what data are required and gathering that data all the way through to actually being able to gain insights?
Thank you. So I would say in some aspects we're quite far along, and in other aspects we're only at the beginning. And let me expand what I mean by that. So data, epidemiological data and related proxy data is the bloodline of forecasting. In order to forecast, you need to know where you are right now and where you've been last week and the week before that. And there's a long tradition of epidemiological data collection by public health officials. There's also a long tradition or a infrastructure for medical data collection. And then over the last 8 years, we've collected a variety of other sources of information, such as Google search query trends and Twitter trends and retail shops and a variety of other things that are related. There's been great progress on collecting data related to the virus, but there hasn't been as much progress on collecting data related to people's behavior. So I think this is the area where we would need to double up our effort and to think creatively about how can we understand how people behave based on sort of macro, non-privacy invasive measures. So I say I'd give us a mixed report card.
Great. Any other thoughts from the panel on that?
Yeah, I would, sure, I'd speak up. I think from my perspective, I think the data is, much of the data, especially data probably from an epidemiological standpoint, has been captured, but it's all been isolated and siloed and still is in a way that makes it more difficult to mine that data, to do things with that data, and then eventually, obviously, to predict things based off that data. I think that from the clinical side, it's probably much better and much more mature. From the operational side, I think it's significantly immature at the regional level, state, federal government level, across the entirety of the levels of government. I don't think that we've done a very good job as a society is collecting that data and being able to do something and act on it. Especially the pandemic has done nothing more than shone a bright light on that inefficiency across all of healthcare.
Yeah, and I would add to that, to Mike's point, and I think Roni's point on the certainly is an issue that is evident when one wants to look at these things nationally. But even Roni can comment when he and my team, his team and my team, were getting on the phone and Zoom meetings at the very beginning of the pandemic, just trying to tackle how would we be able to serve up our information from our healthcare system so that it could be made interoperable with the other healthcare systems in the region, right? I mean, even at a regional level, the obstacles that we had to overcome that Roni had to overcome. I mean, from our perspective, it was relatively straightforward to bring up, create the pipes to send the information on a daily basis. But all of those obstacles were pretty clear early on in the pandemic. And one of the things that, we never really had to act with so much urgency in the past to do these things. And so there's been a lot of lessons learned that we've had certainly along the way.
Yeah, and I would agree with all of my panelists that I think even from a clinical standpoint, we had not prepared our clinicians or our healthcare infrastructure to deal with a pandemic like this, with the tools to help physicians know the timing of how to prioritize patients, of which resources need to be allocated at which point in the patient care journey. And I think, as everyone's mentioned, this has shown an opportunity for us as a global healthcare community to pull our different pieces to better prepare for the next pandemic. And how do we manage population data and kind of distill that into data that can be useful to manage an individual human?
Yeah, thanks everyone. And we'll definitely get back to that point on lessons learned and what we can take away from this as somewhat the positives that we can take away. So I appreciate that. And Jessica, the next question was for you. That is, the past year has, of course, forced a lot of changes and accelerations in work that may have already been ongoing, both in public health and in healthcare. So the question is, what is the biggest pivot or change in your organization over the last year in response to the pandemic?
So I think we're really fortunate to already be operating in a telemedicine type framework. Our platform, physicians can order tests and tools from anywhere in the country and even internationally. I think that the space that we are in modeling complex diseases kind of pulled us into the SARS-CoV conversation. We worked early on with Thermo Fisher to develop this population array where we can start evaluating blood type, biologic sex, ancestry, immune response, and then integrating patient's current environmental state, such as diabetes or comorbidities. And I think that has really shown the need for us to move beyond, as was mentioned earlier, a statistical approach to disease and how we look at this, and how do we create the tools and the data to provide insights for an individual human that may be responding differently to something like an infection than another human. You've got someone with no symptoms and one that's on a ventilator, and how do we understand why? So it's been a very fast year in some ways, in other ways, moving much more slowly than we'd like.
Yeah, and I would like to add, if Zariel, that even though we're going to be talking about AI and machine learning and how does that enable a lot of the changes in healthcare. Certainly, the pandemic has, one of the big things that it changed is that, in my opinion, it made the business much more reliable in data to make decisions, right? And so I would say we operated used to operate in an environment where analytics and insights were, in healthcare, we're so far behind from other industries, but they were still a nice to have. And we have now moved into an environment that, if we are going to be able to identify patients on a timely manner so that we can implement the right interventions, do patient segmentation, all of these different things has brought the need to have data at our fingertips. And that's, even though, again, a lot of what we have seen in our healthcare system is not necessarily all driven by AI or machine learning, I think we would all agree that machine learning and AI insights being at one end of the spectrum cannot be decoupled from our ability to use data across the whole spectrum of analytics maturity and whatnot. And so certainly the advent of the business being much more, out of necessity, but also becoming much more well-versed on how to use data and rely on it to actually map how operations are going to function has been a big positive change that we have seen come with the pandemic.
Great.
Yes. Yeah, I'm sorry. For us, teletracking, I mean, obviously with the pandemic, prior to the pandemic, we'd already made a significant investment in our data platform. It had been 3 years at that point trying to create a SaaS-based solution that aggregated all of our 1,000 hospitals under a single umbrella in terms of data perspective. So we were prepared in the sense that we had data centrally available to us to be able to do things with the help from a pandemic standpoint, given healthcare operations focus. The challenge was with, early on with the pandemic was, you heard nothing more on week one than we need to bend the healthcare curve, right? We need to understand and flatten that curve so that we don't have an impact on the hospitals because this was a different virus. It lasted, people were in ICU for 3 weeks, 4 weeks at times. And they weren't prepared from a hospital standpoint to be able to do that at scale. So, flattening the curve was important. And what we were able to do, it was focus on bringing that information in, bringing that data available in, and putting it out in a way from a healthcare operations standpoint, primarily around capacity and utilization, around bed management. So visibility into beds were important. They didn't know at the early onset of the pandemic how it was going to react, and having that visibility at national level was integral to any level of success with reacting to this pandemic.
And Roni, of course, your work, as you mentioned, your research work was very much focused on forecasting flu up until the last year. Obviously, that's been a pivot.
Yeah, it's been quite a pivot. We also grew during the pandemic by a factor of 5, so from a very typical research group of 7 or 8 people, we became an army of 50 people working around the clock, and everything had to do with data. All the things that were mentioned earlier, Oscar's mentioning of our challenges with getting data from hospitals, from public health sources. My take-home message from this is that to forecast pandemics, you need to be ready to forecast the pandemic before it hit. The systems that are useful are the ones that are ready and tested before events happen. Otherwise, what we've done a lot with our time, unfortunately, is chase problems and run so hard. And by the time we finally caught up with them, they were no longer the problem. There was a new problem that was around. A lot of that had to do with data. Oscar just mentioned that the hospitalization data was not available by HHS until December. As we all know, many of us relied on scraping websites and on going to 1,000 different locations to try to get and corroborate the data. Turns out not all data is alike. There are so many war stories. I think the take-home message is that the time to set up the data pipeline and to overcome all the legal obstacles and logistic obstacles is now. Not when the next pandemic hit, but now when we hopefully have a few years before the next one will hit. And that's what we're focusing on now. We're focusing on preparing for the next pandemic, and it's all about getting the data right.
And we're all thankful for all of your work. So let's get into some of the exciting stuff and talk about some examples of how your organizations are using data and analytics to improve health and healthcare. Let's start first with Michael, and I think you have an example regarding TeleTracking's work and how you've been doing things over the last several months with HHS.
Yeah, absolutely. Back in, it's obvious that we were caught off guard as a society when it came to this pandemic. Back in late March, we were awarded a contract with the Health and Human Services to based off of our already collected data on across 1,000 hospitals in terms of capacity and utilization and bed management, bed availability. We were able to launch within a 12-day period post that contract a website that was an integration point, if you will, not across just 1,000 facilities that we had within TeleTracking, but across the entirety of every health system and hospital in the United States and all outlying areas. And the data that we were collecting was, again, back to the focus on capacity and utilization, therapeutics, medicines, PPE, things that were different that weren't being collected or hadn't been collected. Individually, they're at the facility level within the US. I think each one was doing it fairly well, but how that data came to an aggregate so that you could start using that data in different ways didn't exist. There was no mechanism for the federal government to aggregate that data into a single set, if you will, and then start planning on how to distribute that information, distribute therapeutics, distribute medicines, PPE equipment early on. You needed to have some visibility or some situational awareness into that. So we were brought in from HHS standpoint to aggregate our data, to build a system that allowed the hospitals to integrate that data into a central location as part of the protect.hhs.gov effort. And then that data was composed with or aggregated with socioeconomic characteristics, as well as regional specifics, supply chain data, things of that nature, to do predictions on where might be the next place where an outbreak might occur, where might be the place that if an outbreak does occur, where logistically things might run down or fall apart. So it was also used for distribution of money from a CARES Act standpoint. If you're, how many COVID cases and hospitalizations have you dealt with as a hospital? It dictated that as well. So it was a very interesting project. It was not without its problems. Like I said, we weren't prepared as a society. And as Roni said, I think we needed to be prepared as a society before the pandemic, not during or after the pandemic, because becoming prepared during a pandemic is a challenge. So it was a rough, I would say it was a rough several weeks to get this thing up and running, where nobody was sleeping for days on end, trying to make it work. But eventually we got it up and running to a point where there was some federal visibility into something that was just not existing at the local, regional, state, and now even federal level.
It sounds like quite a feat.
Yeah, and I can certainly comment a little bit on, what Mike was seeing at the macro level, right, of how to support HHS for sort of understanding the national needs and capacity and whatnot. I would say a lot of healthcare systems, us included, we had to figure that at the micro level, right? And so we were fortunate to be, when Mike talks about the 1,000, all the customers that they have, we were fortunate to be TeleTracking users before the pandemic started. And so, one of the things that became clear to us was that, again, some of those same challenges that were being felt at the national level, we never, even though we're a pretty tight-knit integrated system ourselves, most of the hospitals were operating and managing their bed capacities and other things at a local level, right? And when we didn't have, as Roni said, we didn't have any priors to base our predictions, right? We were seeing what was going on in New York and other things. We needed to at least build a system that would allow us to, in as close to real time, understand the capacity of management, bed capacity, and manage it proactively across the system, all the way to being able to flex operating rooms and emergency room beds in the case that our traditional beds were occupied, ventilators, all of those different things. And we, all the data feeds and that we had, we were from being a lot of the solutions that we would support the organization with being on, daily refreshes to going to near real time, utilizing the TeleTracking data to do that, then using different business intelligence tools like ClickView and ClickSense to facilitate that. We then had to move to, we had the bed capacity area checked, but then it became, well, it's not just bed capacity, it's also the workforce that is needed to staff those beds. And so how do we now bring in a different data feed to actually overlay that on top of what we knew about bed capacity and whatnot? And so I just think that certainly we were blessed to be able to have all of some experts in our organization of knowing how the TeleTracking data worked and everything, that we really were able to sort of pretty quickly stand up a solution that allowed us to track this. And to Mike's point, it was a one weekend that there wasn't much sleep in the different teams going on, but that allowed us to sort of stand it up so that we would be more ready than we were before to handle all of these different things. And so again, I think that one of the things I was excited about, I was excited and I am about the panel, is that there's we all have had to address different issues during the pandemic, some at a national level, some of the more predictive level at Roni, and then Ariel, what she and her team are doing at the precision medicine standpoint, and certainly from our perspective, what we have done in the microcosm of our healthcare system. And so I think that and there's a lot of similarities of the things that each one of us has had to do, but with a different twist to fulfill our more focused needs, if you will.
Thanks. I love that example on the capacity management and how the tools and all the collaborations were able to help with that, because it's such a clear use case of data analytics, and it's so obvious to anyone to understand how things could have gone in a much different direction had we not had those capabilities across the country and the world where we do have those. And it's really obvious just to see how important it is that we do have data pipelines and that our readiness is increasing every day to be able to enable things like this. Jessica, any examples that you'd like to give on recent studies or projects?
Yeah, I think right now what we're focusing on is how can we prepare as a global community to use genetic and healthcare data, not only to kind of look at the variability in human response, but how do we track long COVID outcomes? How do we track the variability in how people recover or don't recover from this injury? And how do we look at this? Fortunately, genetic data doesn't change, but a patient's clinical features and needs change over time. And how do we use this baseline of data? Obviously, it has to meet a quality threshold to be useful and to be harmonized. But how do we create the tools that can integrate into a system like Oscars, and from a more macro level, track the resource utility needs from I would say a regional and a national level, and how do we pull in all of our pieces. So I think when we look at partnering with researchers right now to use genetic and clinical data to discover these new insights, that's the foundation that's needed for clinical solutions that have to be implemented at the, in the next event that we encounter, in the next strain of COVID we may encounter. We're still really at I think the beginning of what this pandemic may bring to our world, and how do we build the tools now to more efficiently tackle this. And I think one of the things that we're focused here on Ariel is that translational piece. How do we facilitate, bioinformatic tools with genetic and clinical data to researchers to pull in new clinical solutions and learn from it? And this is where the machine learning longitudinally needs to come in to make the system more efficient.
That's great. It sounds very exciting and gives us some hope for the next weeks and months to come. So I'd love to hear more. We talked a little bit and heard a little bit about how there are data elements that come to mind when we think about predicting or reacting to a situation such as COVID. And a lot of those are along the lines of clinical data and operational data, capacity management sort of data. And specifically when it comes to prediction, there are a lot of elements that one might expect are required, but it sounds like there are some other pieces of data that are perhaps more difficult to collect, such as behavioral data. And I'm interested in what are some of the challenges that your organization has faced, and this question is for Oscar, when it comes to driving impact through analytics and modeling. So of course, you're able to create models and make some sorts of predictions and forecast different things, but where do those other data elements need to fill in some of the gaps in order to really drive change?
Yeah, I mean, I think one of the things that we, I think we and others, right, have found it so challenging is that in order to be able to do predictions, we actually have to have a decent understanding of what is going on, so we can use those learnings or those priors, right, to start to build how we would go about doing predictions. And we certainly saw the complexity that exists for putting aside making predictions, just analyzing data and outcomes in near real time as things are changing, right? And so, when we even trying to tease out what could explain some of the differences in outcomes, for example, that we were seeing between very early in the pandemic to what we saw in the summer, it became clear that there were so many things that were changing at the same time. Different availability of testing, our decisions as to who are the patients that needed to be admitted to the hospital. Once admitted to the hospital, how do we make decisions about using more advanced therapies like mechanical ventilation and other things? And at the time, then, you also introduce a new therapy that is proven to work. In mid-July, the first paper was published showing that steroids, dexamethasone, from the recovery trial actually saved lives. And so the medical community then pivoted, going from, early on, we thought that maybe steroids could make patients worse, and pivoting to, in the right patients, starting to use steroids from in March and April and May. We were using them in 30% of the cases to about 60% of the cases, and starting to see improved outcomes and whatnot, right? And so all of these things needed to be factored in. And then as we started to get more comfortable managing the patients, and our therapies didn't change all that much, we continued to see some improved outcomes, despite the fact that the patients that we were caring for were a little bit sicker and whatnot. And this comes back to what Roni was talking about earlier in that, and what that you mentioned, Zariel, of at the same time that we were doing new interventions on the medical side, there were societal changes that were going on, some more aggressive than others, that could also explain whether, if we were doing more masking, for example, or more social distancing, when there was transmission of the virus, was the inoculum, the amount of virus that was transmitted between subjects different, and all of these other things that could certainly explain what at least partially, some of the outcome differences that we were seeing. And so if one actually takes a step back, right, I mean, certainly just trying to analyze and understand the things that are leading to the outcomes that we were observing was challenging enough. Trying to then make predictions off of that, as Roni can attest and has said at the beginning, was, even more complex, given all of the moving parts that were happening at the same time, and that not all of those moving parts translate into readily available data that one can use to enhance our models and other things. And so it's only quite complex environment, if you will, that we have been trying to operate.
I think complex is putting it lightly.
Yeah, like trying to do complex calculations while riding on a roller coaster and delivering them efficiently. But I think one of the things that has come out is that we are learning as a global community, there are some things that we can implement and to be more predictive. We know that there's certain, Neanderthal locus that people are more likely to actually contract COVID than people without it. We know that there's people with certain regions within CFTR and associated with sickle cell that are more likely to develop pneumonia if they contract COVID. We know that there's a set of variants. If you get COVID, you're more likely to have a very severe outcome. So I think that when we integrate both the outcome data and the results and pull that back into being more predictive, we are, that's where all of the different pieces that everybody brings in are so critical to creating the tools that are going to lead to the better response, better therapeutic alignment, evaluating the outcomes, and then looking for opportunities for new therapeutic interventions based on those segmented insights.
Yeah, absolutely. It all comes back to how can we use these things to drive precision medicine and precision interventions where necessary, whether they're at the patient level or more broad level than that. And I think clearly we've seen and heard a lot about the different challenges that were faced and still are faced throughout this pandemic, and how data analytics can be applied. I'm curious, and let's begin with Michael on this question. What changes to data collection, sharing, interoperability, et cetera, that were driven by COVID do you think will stick around? And maybe are there any that you think will go by the wayside once we're through this to some extent?
It's a great question. I mean, it's obvious to me that we had our last major pandemic of this type was Spanish flu back in 1918 timeframe, so over 100 years ago from a pandemic standpoint. But more than likely, what's going to happen may not be a pandemic. It may be something of a natural disaster or a terrorist attack that leads to very similar concerns and constraints that we have. So we need to look at ways that we still collect this information in an ongoing way, so that we can be prepared for whatever that future event might be. I mean, in an event of a hurricane in South Florida that wipes out, several miles and hospitals for many regions or many areas, you're not looking at ventilators now, but you are looking at generators and distribution of those things that are important. So how do we do this at the local, regional, and federal level, state and federal level? And then from my standpoint, it's all about standards. So we as a society had, when I say a society, the United States is it's built around distribution, right? We have 50 states, we have a federal government, and each of the states operates independently. And those states have some of their own ways to do things. So in order for this to succeed moving forward past this pandemic and beyond, there needs to be a set of standards that define the various types of data sets that would need to be collected prior to those things occurring. So for instance, in a pandemic, you're looking at like SARS-CoV, you're looking at capacity, PPE data, therapeutics, medicines, things of that nature. When you go into some sort of natural disaster, it might be generators instead of ventilators, as I said before. So the focus of the information that needs to be collected needs to happen now, and it needs to come as a standard at the federal level, distributed down to the state levels and regional and local levels, and then being able to be aggregated up in a consistent way on the types of data you need to collect and be prepared for that. So that when the pandemic comes or the natural disaster comes, we're not caught like we were in the last time. We're not caught off guard. And that's the I don't know if it's a challenge. Yes, it's a challenge because the federal government tends to try not to get into the states, get into the state's business. But in this case, you're going to have to if you want to have something that operates at that kind of federal and global level.
I think that leads into our next prepared question here, and then we'd like to have some time for the audience Q&A if possible. So that question is similar to, Michael, what you were just sharing. What have we learned from this pandemic around analytics and tools, and how can that help us prepare for any future events that may require some more capabilities? Let's start with Roni on that one.
Thank you. So first, I want to re-emphasize the point just made by Michael as an answer to this question. The first thing we learned is that we need to be ready with our pipes and agreements right now, not wait. I think all the examples he gave are very compelling. He also touched on another thing that I want to emphasize, which is the fragmented nature of both healthcare market and public health in the United States. We all know that the healthcare is highly fragmented. There are many advantages to that. There's some disadvantages. Public health, not many people know that the CDC actually does not have much legal power. Public health power is vested in states and even more specifically in counties and some cities. And that means that many things that are needed at the global level cannot be compelled, and they can be compelled only to a certain extent in an emergency situation. And maybe that's the way it should be. Maybe there are very good reasons for that, but at the time of a pandemic, cooperation and collaboration and coordination are so critical that we need to work out all of these things ahead of time. And I think Michael was alluding to that it wasn't where it should have been. So it's that fragmented nature that's a challenge for us, and we need to come up with solutions for it ahead of time. The second thing that I learned from this pandemic is we've spent the last 8 years in my group studying the virus, studying flu, studying other respiratory viruses, other not respiratory viruses, how they spread, collecting as much data about them, trying to reconstruct their path, and then use that to project forward where they're going to move next. And our eyes were on the disease and on the virus, not on people's behavior. And my main take-home message was that this pandemic was every bit as much about people's behavior than this is about the virus behavior. And we're so bad at understanding people's behavior, let alone in affecting it. So one other thing we need to do between now and the next pandemic is build both the science and the technology of understanding how people react to different messages, what messages, behavior change communication is it's an existing field, but extremely hard to make progress in it. How do you affect people's behavior? How do you operate in a sea of misinformation? And how do you put eyes on the ground, going back to data, to how people actually are behaving? Where are they going? How are they interacting with each other? How much are they really using masks and so forth? I would mention in this context, we have a mass survey that Facebook was generous enough to allow us to put on their web pages. So they sort of our platform, and then we collect, it's a survey to the general population of the United States, and there's a component of it that's actually done internationally as well, where we ask a good number of questions, around 40 or so questions, and we have about 50,000 full responses every day in the United States. Those of you who are on Facebook, chances are you've encountered that at least once or twice during the last year. It's really a fantastic resource. We're just beginning to scratch the surface of what we can do with that. And it's been a really completely different kind of data, different light shining on what this pandemic has been. The pandemic is not only cases and hospitalizations and ICU admissions and deaths and tests and vaccines, which of course it is, but it's also people going to work, people staying home, people being afraid. Why are they afraid? What are they afraid of? How are they going to respond to a vaccine? How are they going to respond to their test results and so forth? And that's what we're beginning to glean now.
Yeah, and I would just echo what Michael and Roni said. I think that one of the things that we must do is we need to create tools that can help us to harmonize data across various regions so we have the power to actually get meaningful insights. And I think that there's technology that can allow you to balance, personal privacy with public good, and you can anonymize a lot of information and still have access to it. And how do you incentivize and create a structure in which that data can be aggregated, who's responsible for it, who has access to it, how can it be utilized, and then what are the requirements for actually demonstrating results for access to the data and the tools that we build. So I think that there need to be some pretty significant changes to accomplish what we, I think as a panelist, at least agree need to be meaningful steps taken to kind of across, at least within the US, harmonize and get access to and centralize data so we can power, the next solutions.
Yeah, and I would just like to add to exactly what Roni said, in that, as in my area, right, as clinicians, we tend to focus on things like the virus or the physiology of things that happen and whatnot, but maybe neglect or not pay as much attention to all the other things. In medicine, we're only starting to realize the impact that social determinants of health have on outcomes, for example, right? I mean, and if nothing else, the pandemic has shown us the dramatic impact that these different, from a statistical standpoint, we would call them covariates have, right? But certainly our understanding of all of those things is quite limited. And I think certainly not only expanding the harmonization and interoperability of the data, but being more holistic as to how we go about thinking of this. So all of those things that Roni is doing, of trying to really understand more about the population and that will dictate the attitudes and all of these different things. All of these have to be done in parallel with, even the things that we should have done a long time ago, of making sure that our healthcare data is more interoperable and more readily available.
Thanks very much. Well, I think that's probably a good place to stop. on a somewhat positive note. I think as positive as we can get these days when it comes to the challenges of COVID. And, I would just like to say that one of my main takeaways here is that obviously everyone across the world was taken by surprise with this pandemic, but with all the work that's been discussed here, and of course lots and lots more work going on around the world, we will be in a better position thanks to the availability and the utility of data in order to prevent or better address something that could come in the future. So I hope that there's some positive that can come out of this, and that the audience today is able to come away with that knowledge.
So, Zariel, there are a few questions in the chat. Do you want to grab some of them?
Sure, if we have time, if that's all right.
Yeah, we have time.
Okay, great. So I see one is from Audrey. What is
You don't have to
prognosis?
You don't have to just ask mine, but there are other ones in there too.
Yep, it was the first one that came up.
Yeah, there are others in there too.
Okay, here's from Christian Holiday. Roni mentioned ramping up from a staff of 8 people to 50 people quickly. How were they able to do that and be effective quickly?
That's such a good question. It was chaos. It was absolutely fog of war. It wasn't just going from 8 to 50. It was going from 8 who were working on a normal academic schedule of maybe 10 hours a day to 50 who were working 24/7 for months on end. So not only the number of people, but the pace and the intensity went up. So it wasn't easy, and I'm not sure we did it that well always. But one thing that helped is Google has been tremendously helpful to us in giving us not only a financial gift to support our work, but sending us 13 Googlers who volunteered to work with us for 6 months. And of those 13 Googlers, quite a few were software engineers who helped us with the development, but we also had managers, project managers, product managers. So they literally taught us how you work in a large group, which we academics are not used to. How do you set up an operation like that and design a structure of reporting and of tracking? So I learned a lot about management in this time period. So it was a godsend, really.
That's impressive to pull off in a short period of time. And I'm sure that we could have a whole other discussion around the collaborations that were forced and formed due to COVID. And hopefully some of those will continue, and we'll see more kind of that interdisciplinary learning as a result of this. So we have another question from Alec. When building your analytics and models, how does data privacy factor into your thinking? So I think that could be a question for anyone here. Maybe Oscar?
Yeah, I mean, certainly when we take all the data privacy issues very seriously, right? And in our case, because we are mostly utilizing the data and information to allow our clinicians to better care for our patients, right? It's a little bit different than a lot of the data privacy discussions that have happened with monetizing data and some of these other things related to when it gets shared with third entities and whatnot. I mean, the use of data to enhance operations and facilitate how we serve it up for our clinicians to deliver better care has been around for a long time, and it is, a highly regulated environment that we operate on, right? And so certainly, and when I said in the beginning that in our case it's a little bit different than in other entities that might go into secondary or tertiary uses of data. In our case, it's really much more focused for the enhancement of care delivery for our patients. And given that we're operating under a highly regulated environment, the privacy issues and whatnot are in general sort of part of the rules that we operate within, but I'd be interested in hearing the thoughts of others that maybe are relying on entities like ours or other sources to make the data available, where some of these questions are more relevant.
Yeah, I think it depends on the use case. And in this case, most of the use cases were at the generic level. So de-identified data or anonymized data was sufficient enough for the use cases to help across the pandemic. You weren't looking down at the individual level and trying to understand something specific to that individual. So you were looking, completely generically across a large segmentation, and that didn't affect a lot of the use cases during the pandemic. As you start getting into more discrete levels of trying to do the analysis, then obviously because we're in a PHI state, we need to have heavy focus on de-identifying that data. We do that. We have to do that from a storage standpoint anyway. But again, if the use case is, say, internal to UPMC specifically to learn more about something, they can easily use that data at a PII level and work with it. But if they're trying to take that data and use it in more of an external form, it becomes a challenge. So it really just depends on the use case.
Okay, so we just had another question come in. I would imagine that the data accumulates to terabytes, petabytes. How do you consolidate it and provide access to the appropriate individuals so that they can use it effectively? And that is from Mike Perella.
I can take a crack at that because a large part of what we have done in our group is to try to make the data available, the data that we managed to get usable and available to the larger community. In fact, we devised an epidemiological database that is designed specifically for researchers in epidemic spread and for public health officials, for data journalists and for the public. We have several dozen different pandemic indicators or COVID indicators, anywhere from human behavior, answers to questions, through the official, typical cases and deaths to hospitals. A lot of the data from TeleTracking eventually made its way into our indicators. It's available for exploration. It's called COVIDcast. For anybody who cares to look at it, it's covidcast.cmu.edu. And we continue to update it. It's a very fine geographic granularity down to county level and in some cases below. And also it's a daily level of update. So one of the reasons we did it, first of all, for our own needs, for our own forecasting. The second one, as I mentioned, for all the other stakeholders who might be interested in. But the third one is as a example of what we think a national database should be like. Because there's no question that something like that, but maybe at a larger scale, is needed before the first pandemic. And we just decided we're going to try to create it now, learn some lessons, and pass them along.
So I can answer probably both of Mike's questions that he has on here pretty quickly. From our standpoint, we don't talk about it as a database. We talk about it as a data platform. Some people use the term data lake. But the mindset is, from a technology standpoint, for us, we have an ingest layer that brings things in with Apache NiFi. We use Apache Kafka for an eventing layer, and for storage, we use Amazon EMR and S3 so that we can separate compute from storage. So that gives us variability as we need scale. And then we denormalize that and reduce it into a petabyte store that has sub-second access called Snowflake, which is one of our vendors that will be on today. And we make that available either directly to Snowflake or through some sort of business analyst analytics tool like Tableau or Click or others that exist. So it allows you for unlimited scale, but breaking it down into that columnar store based off Snowflake gives you virtually sub-second query speed on volumes and volumes of data at petabyte scale.
Yeah, and I would just say from a population level, I think of something like the UK Biobank, that one of the beauties of a centralized health system is that you do have that aggregate power of the data. And within the UK Biobank framework, I think 20,000 researchers have been able to get access to that data and use it to advance the field of medicine. And I would love to see something like that here in the States, where we create a framework of, genetic healthcare longitudinal data that various researchers can come in, they can contribute to, but also kind of glean the benefits of a centralized resource. So we're not stuck in these siloed little things where our capabilities are limited to what we can internally generate, but we are leveraging the power of this data aggregate. And I think with, encryption and de-identification and all of these different methodologies that are best practices, and how it's secured and how it, is secured in transit, or encrypted in transit and secured at rest. I mean, those are all, things that, as Roni was mentioning, you pull in specialists from all over the place, the Googlers and the data architectures and the security specialists and high trust and HIPAA. We have the tools to do this effectively. We just needed, I'd say, the resources and the drive to accomplish it.
Great. And I think COVID has given us that drive, that's for sure. So we have one last question here, and I think that this is a good one. This is the question from Audrey. What's the prognosis for the future? The next wave of pandemic or natural disasters, what are your confidence levels? So maybe we can ask on a 1 to 10 scale, what are your confidence levels for next time around? Let's start with Michael.
That's a great question, Audrey. I think I'd like to break that down into 2 different ratings from 1 to 10. 1 would be how we would do it effectively at the commercial level and individual organizational level. And I think that I'm pretty confident that we'll be able to address a lot of those things across each one of the panelists and their organizations here at a very high level. A 9 or a 10, I'm confident there. I don't have as much confidence in the federal government and the state governments, to be honest with you, that they'll be able to organize themselves around this and be prepared for the next time. I would put it closer to a 1 or 2, to be in all sincerity, for the federal government to do the right thing and to do it well, so that we would prepare for the next thing in the future.
So, hi, I'm on, and I want to thank you for asking that, Zariel. I'm going to ask Roni, what do you think about that? I'm going to pick on you.
I don't disagree with Michael, but let me try to put a positive spin on it. I think we have a window of opportunity now.
Okay.
That window is the whole world has been educated about what pandemics are and what they can do to you, and how unoptimized our reaction has been, to put it mildly.
Mm-hmm.
So it's a window that could be leveraged into collaboration and sort of work for the common good that maybe wasn't possible before. We need to seize it. The governments are trying to seize it. I'm also, share Michael's concern that governments wanting to do something doesn't mean they can. They don't operate, under the same set of constraints and timelines and so forth. So a lot of it is left up to us, civil society, private organizations, non-profit organizations, public sector, private sector, academia, get together and be prepared for the next one. I want to add one more thing. Michael mentioned, I think correctly, that the next thing may not be a pandemic, it may be some other disaster. But even if you restrict yourself to pandemics, it's very misleading to look back and say, well, the last big one was 100 years ago, and therefore the next one might be 100 years from now. I don't think so. I would put a better than 50% chance that the next big one would be less than a decade from now. And there are very concrete reasons for that. The size of the population, the interaction with wildlife, the rapid mixing of our populations, the change climate, all of these mean that it's a statistics game, and it is not a once in a century. It's going to happen again. It's going to happen in our lifetime, and we have to start working on it now.
Well, we are at the end of our time, and I've got to tell you, I've listened intently, even though I had maniacal dogs barking. I apologize for that. Hopefully you didn't hear it. But there's a lot to cover here. There really is. And Dr. Zariel Johnson, thank you for pulling that together so that we could at least have a little bit of a cogent conversation about some of the issues. But my feeling is that we could have, spent another half hour to an hour digging deep into the space, because it's there's issues around advocacy. That's why I put in my chat. There's things that at the Tech Council we really care about, and trying to tether this is really important. So you've given us, a window into some of the things that you're each grappling with and how you're trying to solve it. And I hope that we can keep this conversation going in many different ways. So I want to give a shout out, deep appreciation to our sponsors, but also thank you, Dr. Johnson, for being, the moderator with us and for the work that you do at UPMC. Thank you, Michael, for the work at TeleTracking. I'm very close to TeleTracking, and I know the intensity and the insanity and some of the good stuff that's happened all in 2020 and now in 2021. Thank you, Dr. Marroquin at UPMC, for your role in just that touches a lot of things, and those things that really matter, whether it's patient focused as well as innovation. So thank you for that. And Jessica, you've done incredible work with your company that have been just the pivot. I had no clue that you're doing that kind of work, and that's really noble and important. So finally, Dr. Roni Rosenfeld, who wanted us to leave with some optimism, and I appreciate that, but you also gave some realism. So I know you're a bit of a pragmatist, so I really appreciate that. There are probably people here that are on this Zoom, and anyone who's listening to the recording, which we get a lot of downloads of, that might want to reach out to each of you for probably a whole set of reasons. So I hope that you're open to that. And like I said earlier, it just takes a village to really grow the tech ecosystem. But I'm proud. I'm actually proud to know that each of you have been involved at the federal, state, and local level in helping people. And hopefully that we can educate people around all these issues and in a way that's digestible. So I want to thank everyone. Thank you so much. We're actually moving right into our technical presentation, so you don't need to go anywhere. You just need to stay put. Thank you to everyone on this current panel. And I am going to now pass the baton back to Manoj Mishra. He is from CGI, and he is going to introduce our technical presentation next. But thank you, panelists, for being with us again.
All right.
Thank you.
Thank you, Audrey. Again, what an informative